collaboration between Palliative India and PalliCovid Kerala. Palliative India is a nationally registered NGO, and its founder is Dr. RAJAGOPAL, who is with me here next to me, who will be taking the class today. And PalliCovid is a group of physicians who has gathered together to make an e-book on the palliative care aspect of COVID. And some of the members are here already in this ECHO.
Hello, good afternoon to everyone. Myself, I am Arun Shah. I am one of the project coordinators in this Institute of Palliative Science. Okay, thank you.
So I request each of you to introduce yourself, starting with Dr. Singh.
My name is Navjeevan Singh. I'm a retired professor of pathology from the University College of Medical Sciences, Delhi. Currently, I work in a small charitable hospital in Ghaziabad. It's called St. Joseph's Hospital.
You are not very much audible, sir. Can you keep the microphone near to your mouth?
Okay. Am I audible now?
Yeah, it's better now.
My name is Navjeevan Singh. I retired as professor of pathology from the University College of Medical Sciences, Delhi, 2 years ago. Currently, I am working with a small charitable hospital in Ghaziabad called St. Joseph's Hospital.
Okay, thank you, sir. Dr. George Varghese. Sir, can you unmute yourself?
Okay, yeah.
Dr. George Varghese.
Yes, sir. Now, we didn't hear you. Please unmute yourself.
Dr. George Varghese, you have a button showing a microphone on the left bottom corner. Can you please click on it? Maybe you can work it out and come back later.
So we will move on to Dr. Abdul Aziz. Dr. Abdul Aziz? No. Let's move on to Dr. Prashant.
Dr. George Varghese is okay now.
Dr. George Varghese?
I'm Dr. George Varghese of College Medical Center, Perurkada.
Okay, thank you, sir. Prashant?
I am Dr. Prashant, Palliative Care Physician, Regional Cancer Center, Trivandrum.
Thank you, sir. Dr.
Ketki. Please unmute yourself.
Sorry, I'm Dr. Ketki. I'm pain and palliative. Okay, I'm anesthesia in a village named Derwan. It's in Konkan in Maharashtra.
Okay. Thank you. Dr. Samin.
Thank you.
Dr. Samin. Dr. Kamarul. Yes.
Dr. Kamrul Hassan. I am from Bangladesh. I am working as surveillance and immunization medical officer for WHO and recently repurposed in COVID-19 response.
Thank you, Dr. Sujeta. Sujeta Jagan. Dr. Neetu. Dr. Neetu. Dr. Christy. Dr. Christy, please unmute yourself. Dr. Sudha. Dr. Sudha, please unmute yourself.
Good evening. I am Dr. Sudha, working as additional professor in anesthesia, RCC Trivandrum.
Thank you, madam. Dr. Biju Raghavan.
Hi, thank you, Sunil. I'm Dr. Biju Raghavan. I'm presently working as a consultant pain and palliative medicine at Rajagiri Hospital, Alua, Kerala.
Thank you, Biju. Dr. Seema. Dr. Seema Mishra. Dr. Seema Mishra, we are unable to hear you. Sorry. Who is logged in as CAS IPA?
Dr. Fabina.
Yeah, please introduce yourself.
Yeah, I'm Dr. Fabina. I'm working as a family medicine consultant at Ernakulam.
Okay, thank you. Dr. Suresh Kumar.
Dr. Suresh Kumar.
Suresh, will you introduce yourself, please? Dr. Suresh Kumar, obviously he is unable to hear us. Can you hear us, Suresh?
Hello?
Yes, sir.
Please introduce yourself, Suresh.
Hello?
Yes, sir. Please.
Am I audible?
Yes, yes, you are.
I am Dr. T. Suresh Kumar, pediatrician, Calcutta.
Thank you, sir. Dr. Abdul Aziz, can you unmute yourself and speak?
Yes, I can hear. I'm Dr. Aziz, working at Muscat as family physician, waiting to go back.
Okay. Thank you, sir. Dr. Mini? Dr. Bablish, please unmute yourself. Dr. Yin Mon? Yeah, Dr. Bablish.
Yes, sir.
Please introduce yourself.
Sir, I'm Dr.
Yeah.
Yes. Hello, everybody. I'm Dr. Yemon from the Ratio Myanmar Country Office. Now I'm repurposing as infection prevention management COVID response, which support to MOHS Myanmar. Thank you.
Dr. Bablish? Dr. Bablish? Yes, please introduce yourself, Dr. Bablish.
I'm Dr. Pablesh Mahawar. I'm a consultant pain and palliative care physician in Rajiv Gandhi Cancer Institute, Delhi, sir.
Thank you, Dr. Bablish. Dr. Safir?
Good afternoon, sir. Myself, Dr. Safir. Right now, I am working in Kerala Government Health Services as an assistant surgeon. I have completed DNP in family medicine. Right now, working in an Alleppey district.
Okay, thank you, Dr. Safir.
Welcome, sir.
Dr. Rahul? Dr. Rahul?
Hello, I am Dr. Rahul. I'm a postgraduate in public health. I'm now volunteering in COVID-19 telemedicine helpline unit, Ernakulam.
Okay, thank you, Dr. Dr. Renuka? Dr. Renuka?
Hello, this is Dr. Renuka, working in CHC Vendable, Trivandrum, Kerala.
Okay, thank you, Dr. Renuka. Dr. Smita? Dr. Smita, please introduce yourself.
Hi, good evening, everyone. I'm Dr. Smita Menon. I've just completed my MBBS right now. I'm currently volunteering at the COVID-19 telemedicine unit in Ernakulam, Kerala.
Thank you. Dr. Lakshmi?
Hello.
Yes.
Yeah, myself Lakshmi Vijayan. I've also just completed my MBBS and I'm pursuing my entrance coaching. And right now I'm working at the telemedicine unit in Ernakulam.
Thank you, Dr. Lakshmi. Dr. Roti? Dr. Roti? Please unmute yourself.
Thank you. Can you hear me?
Yes, yes.
Okay, thank you very much for inviting me. I'm Rudy. I'm internist. I'm a team of palliative care physician from Cipto Hospital, Jakarta, Indonesia.
Where? Where? Jakarta? Okay.
Yes, right.
Right. Got it. Thank you.
Thank you.
Dr. Jose? Dr. Jose, can you unmute yourself? Dr. Fabina? Dr. Rajashree? Madam, please unmute yourself.
Hello, good afternoon. I am Dr. Rajashree. I am a palliative care doctor from Thrissur.
Thank you, madam. Dr. Elizabeth? Dr. Elizabeth? Sorry, we can't hear you. Is there anybody else to be introduced?
I am Dr. Samin. I'm a psychiatrist in General Hospital, Ernakulam. Right now, I'm at the COVID control room. Thank you.
Thank you, Dr. Samin. So, I think we finished introductions and we will, yeah.
I have a question. Would you please
Yeah.
allow me?
Yes.
Actually, I was joined on your third PalliCovid 3, but I lost. That was I am not. I was not attending few classes, and when I got the schedule of new PalliCovid 4, I think maybe the schedule will be changed, or there is some more sessions. But now I saw that the schedule is the same that was inaugurated in PalliCovid 3.
Sorry, we did not quite follow you. Did you say that you had already joined another session earlier?
Yeah.
So you had gone through all the 6 sessions?
No. I missed maybe 2 or 3 sessions.
Okay, you can just choose to rejoin only the sessions that you have missed. You don't have to attend everything. And at the end, we'll have it completed. Okay.
Okay, sure. Thank you.
Thank you. I think we will move on to the session now. So, the relevance of palliative care in COVID-19, and this session will be taken by Dr. RAJAGOPAL, who is the founder chairman of Palliative India, and he is the director of Trivandrum Institute of Palliative Sciences. Welcome, sir, and it's over to you.
Hello, everybody. So, as Sunil introduced, the name is Rajagopal. I am a palliative care physician, originally trained as an anesthetist. I work in Trivandrum. I also direct this institute, which is a WHO collaborating center. I don't know if I don't know that anybody from the Southeast Asian region office of WHO is attending today, perhaps not. But I'm glad they transmitted the information so that we have people from 5 countries attending this course. There are a couple of people who have joined here as my invitees. One is Dr. Prashant from Regional Cancer Center, and also Dr. T. Suresh Kumar. Suresh found that we were not quite audible to him. Suresh, generally I understand that everybody else can hear us. So maybe it's your own computer settings, I don't know. So thank you, Prashant and Suresh, for joining in as observers. And also to Manjusha from Delhi for joining in as an observer. So, dear friends, we are doing this session so that some palliative care can be introduced into treatment of COVID-19. During the next few weeks, What the world will be like in early June is not known to us. We don't know. By that time, in India, community and in many other countries, community spread would have occurred. People of my age would be particularly at risk. Some people of my age would have self-quarantined, maybe at less risk than those of us who still get out of the house. What am I saying? What I am saying is that all that I am going to talk about today and all that we will discuss during the 6 days could well be applicable to me or to anybody like me. Today, the way the world is today, we are not talking about someone else, the patients. It could well be applicable to ourselves or to our loved ones. It's also very likely that before it has all ended with a vaccine or with herd immunity by the end of the year, hopefully, most of us may know somebody very close to us who has been lost. So this is one fact that we will remember now. We are going to talk about those elements of palliative care that would be applicable to the management of COVID. I hope all of you are able to see the screen. These would be my main objectives today. Today is only an introduction, mind you. We are going to the details, or other speakers are going into the details over the next 5 days. We'll get today clarity about what is palliative care. Very often there are misconceptions. We will try to overcome the misconceptions. We will, at the end of this session, hopefully, be able to recognize those elements of physical suffering, psychological suffering, social and financial suffering, or spiritual suffering that would be relevant to anything in healthcare, but particularly to COVID. And then we will go on to the need for appropriate end-of-life care. These are the 3 major objectives that I have in mind. My colleagues Raju and Arun will be sharing with you this presentation. Please look at the link given here. That's the e-book, the electronic book, which is available for free download. Do please download the book. Keep it as a sort of reference. It will have flow charts to guide you. In today's session, I see that there are only a small number of doctors who are actively in COVID treatment. But maybe by the end of the month, many more of us might have treated a COVID patient. So please keep that ebook handy. And we recommend that PalliCare app, which is again available for free download, be downloaded and kept there. I think I would strongly recommend that everybody keeps their microphone muted. 1 or 2 people, I mean, we can mute them from here, but you can unmute yourself. And 1 or 2 of you seem to have background noise, which will disturb the whole session. So for the proper conduct of a session like this, it's essential that those who are not speaking remain muted. And in between, if you want to interrupt me and speak, ask a question, or seek clarification, please raise your hand and my colleagues will give me the hint to stop and let you ask the question. And 1 more thing, my apologies to those who find it difficult to follow my accent. So to those from Myanmar, etc., where Indian accent may be hard, I'm sorry. Please note down the things that are not clear, and by all means send a chat message or an email, and we'll clarify your doubts later. So shall we move on to try to see whether we can achieve the 3 objectives that we have listed there. And the first, of course, is understanding what precisely is palliative care. But before I go on to that, would you like to give yourself a moment to think in your concept, what is palliative care? Okay, you have had a moment to think. I am not asking you to speak now. You have an answer in your mind. And as I move forward, you see if it fits in with your concept. The first sentence that you see on the screen is part of the official WHO definition of palliative care. Not the whole sentence, just taken the important part of it out of the definition. At the end of the presentation that you will have access to, the reference that's marked as 1. Both these references are quoted there. It will be at the among the last few slides of the presentation. So, please mute yourself, everybody. That doesn't matter. I mean, this usually happens in the first session. Before everybody has worked out where the mute button is, how to unmute yourself, doesn't matter. We'll get there. So, as the first line there says, according to the definition, oh, I'm sorry about that mistake. Raju, please correct it later. It's 2002, not 2012. 18 years back, WHO defined it as improving the quality of life of patient with life-threatening disease and other family. Life-threatening disease is the phrase. Remember, it doesn't say chronic. If your thought fixed palliative care close to chronic diseases, no, nowhere does it say that. No definition includes the word chronic. It's for any life-threatening disease. The principles would be applicable. Sorry, ladies and gentlemen, some of you are still not muted, and there is conversations happening within the family which is disturbing the session. So please keep yourself muted. So back to the screen, ladies and gentlemen. I also have a reference given to a Lancet Commission report. The Lancet Commission on Access to Palliative Care and Pain Relief, published in 2018, uses the phrase serious health-related suffering. If there is suffering, it needs to be treated. Hey, would any of you argue that a doctor's duty is only to treat diseases, not to attend to suffering? That would be unlikely, wouldn't it? We don't talk about it, but don't our patients and their families come to us expecting relief from suffering? So in the context of in the context of COVID-19 also,
Sorry, we have some problem here. Who is logged in as Galaxy 204846 is making some disturbance. I request you to please keep you muted.
So, just as happened 2 years back with, or 3 years back with the Ebola epidemic, the suffering is horrendous. And that is what we will be treating here. I hope this concept is clear to you. That palliative care is about treatment of suffering. To all the doctors, your medical education and my medical education has been mostly focused on diseases. Your biochemistry, anatomy, physiology, and then your microbiology or pathology and pharmacology were all aimed at understanding diseases and understanding pathology. And then your clinical studies were focused almost exclusively on diagnosis and treatment. The one department that went on to a little more was your community medicine or public health, where prevention of disease was also talked about. Still, it was mostly focused on diseases. What we do here is to treat suffering, identify causes of suffering, and try to treat them. And as we know, COVID-19 does cause enormous suffering. Next, please. So let us have it very clear. Palliative care is not only for cancer. It's not only for any one particular disease. The diagnosis is not a criteria. And it is not only end-of-life care. A lot of people associate palliative care with end-of-life care. It is not only care of the dying. And actually, a World Health Assembly resolution of 2014 urged all member countries to integrate palliative care into all healthcare. And then remember, palliative care is not only for the patients, because again, everybody here who has gone through a serious illness in your own family would recognize that with the patient, the whole family suffers, particularly so in the case of COVID. All of a sudden, your loved one has been having fever since yesterday. Today, he is taken away to hospital, and you never see the person alive again. This is happening today. So, care of the family comes in. The suffering is particularly bad because of the rapid onset, fast progression. You don't have time to adapt to the changing situation. It's too much of a shock. And in elders with comorbidities, the prognosis, it's indeed is poor. 23rd, a paper was published from New York, where they studied what happened to 5,700 patients. Out of them, 320 had come to a logical conclusion, and only 88%, and of those who had gone on ventilators, of the 320 who had gone on ventilators, 88.1% died. And that mortality was even worse in the age group above 75. Both the patients and the family suffered from the isolation. Isolation is not an easy thing to bear. Even when you are healthy, a day alone is not easy for many people. And the remaining lifetime in isolation is not easy to bear. And even when there are people caring for you, you don't see them. You see only the protection equipment or PPE. You see only masks and caps. And for the treating team, there is this question. At some point of time in every country, we may come to a situation where their facilities are limited. Number of ventilators available are limited. How do you make a choice? Is it ethical to make a choice based on age? Who are you to say that my life is less worth living than that of a younger man? Is that fair? So many ethical dilemmas will come up. Personally, I believe it is, but that's a personal opinion. Personally, I believe that for those with comorbidities and of those who are elderly with comorbidities, the chance of success from a ventilator are less, and therefore they should be triaged out if possible after informing them and with their concurrence. So these are the situations these are situations where particularly suffering from COVID is difficult. Next. Now, a lot of people in this group are trained in palliative care. They would all be familiar with this concept. From the founder of palliative care movement, Dame Cicely Saunders, that palliative care is for improving quality of life. When quality of life is reduced by a conglomeration of physical, social and financial, emotional and spiritual issues, note that each one circle is encroaching onto the other circles. Physical problems will cause social, emotional and spiritual problems. Similarly, each can cause the other. So these are the various things that we will have to take care of. As far as the physical factors are concerned, particularly those amongst you who are actually COVID treating doctors might have come across this. Fever and myalgia. Oh, we have all had fever. We have had muscle pains when we are having an attack of flu. We know what it is, but it appears that it can be beyond your imagination. The suffering of myalgia. Cough, incessant cough can be so troublesome that the person cannot get a moment of sleep. Secretions can be particularly troublesome, so can breathlessness be. And for a lot of people who are willing to think about your own death, you will agree with me that not being able to take in a breath is a frightening thing. And what was not often talked about earlier, but what is talked about more and more nowadays, is the restlessness, delirium, and agitation that commonly accompany COVID-19, and which is very great suffering and needs to be treated. That was the physical factors. The emotional factors, absolute fear. Am I going to die? Will I see my family ever again? Oh my God, how can I bear this when I cannot bear to see my family again? The guilt. If only I had quarantined myself. If only I had not taken that flight. The anger of the medical system. I mean, how dare you take me away? The anxiety, the intense depression that can result, and the grief. Anticipatory grief is not the grief about what's happening now, about what you fear will happen tomorrow. I'm losing this world, I'm losing everything, I'm finished. That kind of grief. These are all real. And is there something you can do about it? Indeed, there's a lot that can be done about it. We cannot make the situation absolutely beautiful, take away all the suffering, but much of the suffering will be unnecessary. And over the next 5 days, that's one of the things that you will see how we can take care of some of these to the best of our ability, even with personal protection equipment. Separation from the family, not having been able to do the important things that you should have done earlier, unfinished business. Oh my God, why didn't I make a will so far? Why didn't I convey enough information to my family? They don't even know where the bank accounts are. What's going to happen to my business? There can be such a lot of problem. Oh my God, I wanted to make up to my brother with whom I quarreled 3 years back. No, there will be no choice. The stigma and the discrimination, and you all have read about it in India itself. There have been instances where somebody who had been quarantined or somebody who had had a, I think one of you is yawning so prodigiously and everybody is looking at the uvula, which is very interesting but rather sleep inducing. I'm sorry that I am not able to make it interesting enough to prevent those yawns. The stigma has in some instances between such that people were persecuted just for the reason that they have had a contact with somebody with COVID. Absolute stigmatization and discrimination has resulted in huge suffering. And the financial considerations also can be very challenging. Next, please. And the spiritual issues. When you talk about spiritual factors, many people may think only in terms of faith or religion. The questions like, why me? Why did God do this to me? And everything about their faith that they have believed in is being challenged. For example, for a devout Catholic, for whom a last communion is vastly important. If the last communion is important and that it cannot be achieved within the isolation ward, what kind of hell will that person be going through? We are all connected to this world through some things. What connects you to this world? Would you like to give it a moment of thought? What is it that connects you to this universe? A lot of people may say God. A lot of people may say my family. But you would also note that many of you will be connected to your own home, your environment. Especially we elders, very often are not comfortable in anywhere separated away. You young people would take your parent with a lot of love to the 30th story apartment in Mumbai. And the person goes practically mad because you have disconnected them from their universe. So the isolation is not only loneliness, it's also being taken away to another world. And then the person starts wondering, what's the point of living like this? Oh God, I wish I were dead. I wish I had the power at least to commit suicide. Because there is no point in living like this. Anyway, I seem to be dying. I wish I could die now. And legacy is about leaving something behind. I mentioned a will, the person, the material possessions. But it's not only that. Being able to tell your children once more, I love you, becomes so very important. Telling them, like, I have kept this for you. You must have my collection of books. Saying that to a child becomes so important. And here we are losing the opportunity for all that. I have, for the last 7 minutes, been going through some common physical problems, some emotional problems, some social problems, and some spiritual problems that are common to COVID-19. Just so that we understand what it is that we are going to deal with. One of the dilemmas that we'll have here is how aggressive should artificial life support be? Personally, ladies and gentlemen, if one of you happens to treat me, you should know that I have written my advance directive. I have left an instruction that if I do develop respiratory failure, I should be given only palliative care. I should not be connected to a ventilator. I am an anesthetist. I was an intensivist, and I know what it's like. If I had hope of survival with a reasonable quality of life, I would opt for it. But now, in many instances, for the elderly man with multiple comorbidities, palliative care alone is indicated because in artificial life support system stretches out the dying process. It doesn't really prolong life. It is stretching out the dying process because that's hardly any life that is there except for a beating heart. So the answer is in triaging the situation. A team that is separate from the treating team makes an evaluation of the patient's condition and decides which course to pursue. If you believe that proper artificial life support is not likely to be useful, we start counseling the patient and family. This is what happens. This is what is happening to you. We believe that we would like to keep you as comfortable as possible. We will do everything that is necessary for you. You will never say nothing more can be done. That's not true. So long as their life, there is always something to be done. But that may not be to do meaningless things, like pushing an endotracheal tube down into somebody who is dying anyway. So that triage is done, and then appropriate action is followed. So as I said earlier, this finding from New York, 12 New York hospitals, shows that for elders, the recovery was only 11.9% after artificial ventilation. Well, that's not a bad number, but that's for all ventilated patients together. When they took only those above 75, the results were particularly bad. So, if I am your patient, what would be the best care for me? Please tell me the truth. Not bluntly, find out what my fears are, find out what my anxieties are, and then when I am ready, give me the right information. Allow me to be part of the decision-making process. In one of the sessions that follows this week, this is what will be dealt with in detail about how to communicate with a person and how to communicate such bad news. Next, please. This quotation again, I have in the last but 2 slides, I have given the reference. This is from an Indian Council of Medical Research document published in 2018. What's the duty of care of a doctor? The duty of a doctor is to alleviate suffering. It is to cure sometimes, to relieve often, and to comfort always. And there exist no exceptions to this rule. If I am your patient, your duty is to relieve my suffering, cure me if possible, but always comfort me. Nowhere in medical ethics or in any of your medicine textbooks does it say that a doctor has a duty to prolong the heartbeat for a few hours more or days more if it causes suffering. That is an artificial belief instilled in by us during the last generation by an aggressive medical care system. That is not medically, ethically correct. So the course of action would be triage, to decide, to make an estimate, not decide, estimate of how successful treatment can be, then a shared decision making with the patient and family, planning care in advance, and continuing to provide symptom control focused on comfort, while at the same time continuing psychosocial-spiritual support. Please. And care for the family has to continue. In this case, the family cannot visit. But is it impossible that they will not be able to see the loved one over a mobile phone? Will electronic ingenuity be able to solve such problems? Don't they deserve that last conversation and a view? We will have to, like you, busy doctor, will not be able to do it alone. But if, as we hope, there will be enough social workers and counselors coming in to help, then the families can be helped in the process of acceptance. Then pathological grief and treatment of depression will be less necessary, less likely. And when we talk about family, remember that children of families are usually ignored. They can be very vulnerable to suffering. And when we talk about supporting the family, the children must be particularly remembered. Next, please. An article that appeared in the Lancet about 2 weeks back, or less than 2 weeks back. Again, the reference has been given later on. Recommends that one of the essential requirements for adequate comfort for the COVID patient would be adequate supply of opioid medication. All COVID treating doctors should have palliative care training. Telehealth facilities must be made improved, and technology must be used for treating patients and families, for communicating with patients and families, and to make virtual visits possible, and for this shared decision making. I stopped there. Today we had, in the first session, had the self-introductions, which also took some time. We still have some time for discussion, but practically everything that I have said so far by way of introduction will be dealt with in greater detail over the next 5 days. But in the meantime, Dr. Sunil, will you please facilitate the discussion?
Thank you, sir. The session is open for discussion. You can either give your comments or questions.
If you have a comment or question, please raise your hand and somebody will unmute you or just start speaking.
Dr. Singh. Dr. Singh.
Thank you very much, Dr. Rajagopal, for that very lucid interpretation of what is happening to us. As one of the elderly in this gathering, I can understand a lot of your concerns and what you may or may not be able to do about them. The question I have is, what can an old man like me, sitting at home in lockdown, I'm in Ghaziabad, do without going out?
Dr. Singh, thank you for that comment. Yes, indeed, self-quarantine is the one way of protecting oneself. Some people in essential services, etc., find that a little difficult and hard. But thank you. That is an advice to the world at large. If you are elderly, stay at home and protect yourself. Thank you, Dr. Singh.
Anybody else?
Can I rejoin that question?
Please. Please, Dr.
You are just about my age, maybe a little older. You are not at home.
That was the dilemma of the healthcare professional. Most of the services nowadays are manned by young people. So what I have done myself, Dr. Singh, thank you for the concern. I mean, even in a session, you are expressing your care for me. Thank you very much. So I don't see patients now. Sunil and his team have taken over patient care. I am confining myself to some things for which I believe I still need to contribute. I am not staying home, but I am not actively engaged in patient care. But Sunil, Dr. Singh raises a point about which I need to think more. Thank you, Dr. Singh. We need not take a decision here and now, but I greatly appreciate your comment and your concern. Thank you. I'm sure somebody must be having some comment or other.
If you are unable to speak, you can also type your questions on the chat box.
Very clearly, no question has come up, and in a way that's understandable because I have not gone into the detail of any subject, and the questions I am sure will be forthcoming when you go into the details, when the others go into the details at every session. The observers, Prashant, Suresh, any comments?
Hello, sir.
Prashant. Dr. Prashant is palliative care physician at Regional Cancer Center, Trivandrum.
Actually, when we address the needs of the palliative care needs of the patients of COVID-affected patients, many may be actually confused that actually, COVID is a curable or rather treatable patient. And, what could be the importance of palliative care, providing palliative care to such a patient where maybe a clinician can completely cure it. But in the session, our beloved Rajagopal sir has clearly stated, how in which context and to what extent palliative care is very important for the management of COVID-19 patients as well, even for the fear, even for the stress that they undergo. Actually, the incorporating principles of palliative care among the physicians treating COVID-19 will take a long way in the management of the COVID-19 patients. So my humble request to all, all of us are committed for palliative care. That's why we are here. My, my humble request to all of you is that, in the forthcoming sessions, we must be able to bring in more, more doctors involved in COVID-19. And I would rather suggest one thing is that many of the COVID-19 treating physicians would be very busy during the daytime, and it would be better if we have a session on the evening, maybe from 8 to 9. And I think one other thing is we also need to train nurses involved in COVID-19 management, because both can help. I think both these suggestions may be able to help the situation. Thank you very much, sir. Thank you.
Prashant, you had made that suggestion about the timing personally to me earlier also, and we have decided that if there are enough people who want that an evening session, COVID treating doctors will organize it. Thank you, Prashant. Anybody else?
Hello, sir.
Who is speaking? Suresh, hello. Suresh, were we audible to you? You had complained earlier that the voice was too soft.
Okay, I'll talk. Anyway, it was a very nice presentation. It was a very nice presentation. As an outsider of palliative care, I had the opportunity to learn the basic principles, especially with regard to COVID. As you said, elderly people who can't be treated or who can't recover from the severity of the illness, they could be given palliative care instead of putting in ventilator and giving them more troubles. Anyway, that kind of thing has to actually get the consent of the people, patient, family, etc. But thing is, nobody has thought about it. And from some of the interviews I heard, I heard that morphine will be very useful in the management of pain, even in COVID patients. Is it correct, or are you using it?
Suresh, in the subsequent sessions, we'll be going into the details of this. But let me make two comments about your points. One, yes, for those in whom artificial life support is not going to be of use, palliative care certainly has a big role. But not only there, even during the active treatment, whether it's myalgia or breathlessness or agitation, even in people who can be salvaged, palliative care has a role. When you are treating aggressively, concurrently, that's all what the World Health Assembly recommends. Integrate palliative care into COVID treatment or any disease treatment. So, for example, the myalgia is treated, you will see it in the subsequent sessions, systematically. That's not only for the dying people. So palliative care is not only for the dying people. Palliative care is for every patient who has a suffering along with the disease-specific treatment. Opioids, yes, the greatest relevance for opioids in COVID-19 is for treatment of breathlessness. This may sound like a revolutionary thought to people in India because palliative care has not been taught to medical students till 2019. In the West, where palliative care is taught routinely to medical students, they are familiar with this. American Thoracic Society's guidelines, you can see the medicine that they recommend for the breathlessness in COPD. We all studied that as a contraindication. The drug of choice is morphine. Not 15 milligrams, but in small doses. A small 2.5 to 5 milligram morphine dose given 6 hourly can be the best treatment for breathlessness. That dose does not cause respiratory depression, but decreases the sensation of breathlessness. So opioids do have a major role, mostly for treatment of breathlessness, also for pain in some people. And the couple of questions that came up in chat. How do we take away the stigma? Yes, and Prashant has given the response. Write about it, talk about it. The public have the fear of the unknown. When they don't know what it is, they are scared. We are all afraid of the unknown. We have to demystify it. Awareness programs. You write about it, you speak about it, and that's the only way to overcome the stigma. Thank you, Prashant, for that comment.
Any more questions?
It's a very impressive presentation, and we are looking forward for the further sessions.
Thank you, George. Thank you very much. You want to tell about the feedback?
So if there are no more questions, I think we can close the session. Before you leave, we are launching a feedback survey questions. So please do this survey, and so that it will help us to improve further.
And our particular thanks to those who came from other countries, Bangladesh, Myanmar, Sri Lanka, Oman, Indonesia. Thank you for joining us. And everybody from within the country also. Thank you for joining the first session. There's a question from Dr. Suresh Kumar. Patients above 65 are focused much. Palliative care focusing on the elderly should be incorporated. Thank you, Suresh. Most of what we talk about will be particularly applicable to the elderly, and we'll bear that in mind during subsequent sessions.
I hope all of you can see the questions for feedback.